Ladies and gentlemen, welcome to my channel. I am Dr. Aurangzeb, consultant cardiologist, and the topic that I have chosen for today's presentation is anticoagulation therapy in patients with deep vein thrombosis. Both DVT and pulmonembolism are a very vast topic, overlapping cardiology, pulmonology, internal medicine, and I have focused specifically on the anticoagulation therapy in these patients, particularly patients with deep vein thrombosis from a clinical perspective. I hope this presentation will help you learn something practical regarding management of your patients. So let's proceed. The outline for today's presentation is what is anticoagulation therapy for patients with DVT, initiation of anticoagulation therapy, what is the guidelines recommendation, what are NOACs, and how they differ from vitamin K antagonists, what are their benefits and what are their different types, along with brief literature review. Long-term anticoagulation therapy. Is this indicated for every patient, or what are the best candidates for long-term anticoagulation therapy? Is this safe in every patient or not? This will also be issue that we are going to focus on. What is the optimal duration of anticoagulation therapy? And finally, what are the limitations of anticoagulation therapy? We know that anticoagulation therapy is the mainstay of treatment for thromboembolic conditions, whether it's pulmonary embolism, deep venous thrombosis, or other arterial side or venous side thrombosis. So the anticoagulation therapy is the mainstay of treatment. And the patients who receive anticoagulation therapy for DVT, there are no immediate sequelae in up to 90% of the patients who are treated with anticoagulation therapy. The next advantage of anticoagulation therapy is that the therapy is non-invasive compared to catheter-based therapies and thrombectomies. Less complications associated with anticoagulation therapy, and anticoagulation therapy improves morbidity and mortality in these patients. In this slide, we will briefly go through how to initiate anticoagulation therapy for patients with deep venous thrombosis. The American College of Chest Physicians evidence-based clinical practice guidelines will be followed, and they state that when you are starting a patient on an anticoagulation regime in the short term, first we will start the patient on either subcutaneous low molecular weight heparin or fixed dose unfractionated heparin, or intravenous unfractionated heparin or subcutaneous fondaparinux, and a vitamin K antagonist should be initiated with low molecular weight heparin or the unfractionated heparin or fondaparinux on the first day of treatment. The initial treatment should continue for at least 5 days and until the international normalized ratio for the vitamin K antagonist is 2 or higher for at least 24 hours. Single or twice daily injection of low molecular weight heparin is preferred because it has the advantage of fixed dosage, more safety, and it doesn't require any monitoring. We all know that oral anticoagulation therapy is not limited to vitamin K antagonists and warfarin. NOACs or novel oral anticoagulants are also increasingly used as first-line medications for patients with DVT, pulmonary embolism, and other compelling indications. These are factor Xa inhibitors and direct thrombin inhibitors. They are superior to warfarin in many aspects. For example, they don't require the INR monitoring, and they don't have those potential drug and food interactions for which warfarin is notorious. These medications include betrixaban, and it is indicated for the prophylaxis of VTE in adults who are hospitalized for acute illness, who are at risk for thromboembolic complications owing to moderate or severe restricted mobility and other risk factors that may cause VTE. Rivaroxaban is effective in preventing VTE recurrence as administering enoxaparin followed by vitamin K antagonist, and it may be associated with less bleeding. And the efficacy and safety of rivaroxaban was established by the landmark Einstein DVT and Einstein PE trials. So for extended treatment and for prevention of recurrences, rivaroxaban is effective. For dabigatran is non-inferior to warfarin in extended treatment of venous thromboembolism. Low risk for major or clinically relevant bleeding than warfarin. This is the advantage of dabigatran, and their efficacy and safety was established in the RESONATE and REMEDY trials. The Hokusai VTE study studied edoxaban with similar outcomes. In addition to what I have not mentioned in these slides is epixaban. It's also very effective in treating these patients, uh, particularly those patients who are elderly or who have renal impairment. Now let's discuss how long-term anticoagulation therapy can be an option for these patients. We know from the literature that the incidence of recurrent thrombosis is 25% if anticoagulation is interrupted within the first 12 weeks of therapy. Now a question arises that if this is the case, then this long-term anticoagulation therapy should be suitable for every patient, but that is not the case. So it should be done individually in every patient after assessing their risk-benefit ratio, their bleeding risk, their recurrence risk, the risk factor profile. The goal is to prevent recurrent venous thrombosis or thromboembolic events. Now the question arises that how long should anticoagulation therapy be continued in patients with deep venous thrombosis, and we know from the guidelines that 3 months of anticoagulation therapy recommended for the first unprovoked VTE in those patients who are at high risk for bleeding. However, if the patient are low to moderate risk for bleeding, indefinite anticoagulation should be recommended in those patients. With regard to aspirin, it is recommended to prevent recurrent venous thromboembolism in patients with unprovoked proximal DVT or PE following the cessation of anticoagulation therapy. Although anticoagulation therapy has revolutionized the treatment of DVT and pulmonary embolism, it has got certain limitations. For example, progression to symptomatic pulmonary embolism in 2 to 4% of patients receiving anticoagulation for DVT, and it does not remove the thrombus. Recurrence in the setting of a pulmonary embolism occur in 8% of patients despite anticoagulation therapy, and 30 to 45% of those patients dies of the recurrent event. Anticoagulation does not reduce the incidence of post-thrombotic syndrome. Thank you, ladies and gentlemen. I will request you to please subscribe to the channel, press the bell icon, and support us on YouTube. Thank you.